Yes.
Hi. Okay, you're our new favorite person, so. Hi.
Nice to meet you.
Nice to meet you too.
Thank you. This is John.
This is my wonderful husband.
Okay. This is Melvin. He's one of our medical students.
Hi, medical student. You're in a good room.
Amy was telling me a bit about you. I'd already looked through your images,
Yeah.
and I'd already gone through your images with our radiologist.
Right.
So, welcome. And now, what I didn't know until today was you do have a family history of osteosarcoma, is that right?
My mother had it, she got it
Wow.
at 63, I'm 63,
That is
and she died at 67.
highly uncommon,
Yes, it
though there is an unusual second peak later on in life. But did she have anything like Paget's disease or radiation?
So I'll tell you quick, because she had like skin cancer when I was in high school, okay, and they took it out. They said it was a really big thing. They took it out, that was over. Then she had a lumpectomy probably when I was in college, and that was no problem. And then they told her she was 5 years fine, and she started getting pain in her neck and her back, and she went to chiropractor after chiropractor after chiropractor. And then finally one of them said, you need to go to a neurologist. Went to a neurologist, he said, you need to go to an oncologist. She went to an oncologist, he said, you have 6 months, go home, get your shit together. My father said, we're going for another opinion. They went to another oncologist. That one said, I can give you 2 years. And his partner walked in the room and said, and I can make it pain-free. And my mother said, I'll take it. And then 2 years to the day he said it, she died at 67. But it was osteosarcoma. But in her end, when she was in hospice, like when she was like at the end, I looked at her chart and it said it had now metastasized to her pancreas. So probably pancreatic cancer is the last thing that took her out. But the sarcoma was what lasted about 4 years. So 2 years of her not knowing, and then 2 years of her, being treated.
That's,
Yeah.
to call it tragic.
Yeah, at 67, that's pretty
She was a
much.
heavy smoker all her life till you had
But
the
she
baby.
stopped in like 1986. When I had my baby, she stopped. Yeah.
So what is interesting is that it's unusual to have osteosarcoma.
Yes.
Exceedingly unusual.
Yes.
It's typically seen in adolescence.
Right.
There's another peak later on in life,
Mm-hmm.
in the 50s, 60s, in that area, but that's typically associated with certain predisposing conditions.
Right.
So if it truly was an osteosarcoma,
Yeah.
not another malignancy that had metastasized to the bone,
Right.
if it really was a true osteosarcoma without an underlying cause like Paget's disease, like radiation to those sites,
So she
It
had
does beg the
radiation.
question.
She had radiation for her breast cancer,
that may be it.
and then the sarcoma was in her neck and right around here.
Yeah, so
that
it's
could be
possible that it was actually starting here in the
Yeah.
area.
I just remember she had a
prior
tattoo
radiation.
here, and
Okay.
she had a tattoo for the radiation.
That would make more sense, and
Okay.
it probably was a radiation-associated sarcoma.
Okay.
Because if it wasn't, it does beg the question as to whether we needed to, not needed to,
Mhm.
or whether there would be a benefit to some genetic evaluation. to
Right,
try
right.
to figure it out.
Right.
But if we have an identifiable cause such as prior radiation in the area,
Yeah. So she
while-
was 5 years clean
Yeah.
from the breast cancer, and they said, you're out of the woods.
and there is usually a latency after, and actually the most common, I would say the typical latency is like 10 years, but
Yeah.
it has to be at least 3 years to
Yeah.
say radiation-induced sarcoma,
Yeah.
radiation-associated sarcoma, and in that case, I'm not sure that we need to rush to a genetic evaluation.
Sure. Yeah, because it
Especially
sounds like
since-
there was a causative piece.
Yeah,
I understand what you're saying.
Exactly. Okay, so that tragedy aside,
Yes.
let's talk about you.
Okay.
You identified this, and how long have you noticed this?
So I noticed it sometime in around like January.
Okay.
and reported it to my doctor in the beginning of February, because I do yoga every day, and every time I leaned on it, I felt like I had a walnut there,
Yeah.
and it hurt, you know, but the pain got worse as time went on.
Was there an inciting event?
No.
An injection to that area?
No.
A trauma? A fall onto it that we
No.
can recall over the last?
I
6
had
to
a
12
fall
months?
in August of 2021, 2 years ago, but I fell on this side.
Yeah.
Yeah.
Okay. Any other lumps or bumps that you can identify?
No.
Okay. I like this.
Yes.
This is,
Grateful
I
Badass.
like it. So, pardon my French.
No, you're fine. So I'm gonna show you,
Yeah.
it is right there.
Okay. Yeah. Is it tender when I'm pressing on
Yeah, a little bit.
it?
There it's tender.
Yeah. Does it shoot down your leg?
Yes, it does.
Okay. Where down your leg?
To like about here.
Okay, got it.
It kind of touches on our muscles, so it stretches the muscle.
Yeah.
I bet. Okay.
Yeah, for some reason, going down the stairs is worse than going up, and sitting down in a chair is worse than getting up in a chair.
Lift up to the sky. No. Straighten out the knee. No. Now pull down, or bend the knee really strong. Pull. Is that painful?
Yeah.
Okay.
Got it. Not surprising, because it's
Okay.
right near where your hamstrings are.
Yeah.
It's really up in your gluteal muscles.
Yeah.
But it's right near where your hamstrings are, so when you're pulling on your hamstrings, you're pulling on this thing.
Yeah, and bending over to pick something up is hard.
So there is something in your gluteal musculature.
Correct.
So I'm gonna pull this up. I'm using this one. It's not the best sequence of the
Okay.
MRI
Right.
to look at it, but it highlights the area.
Sure.
So on this one, you're laying down on the table like
This is my slice.
this. Your foot's over here where my hand is.
Oh, okay, this way.
Your head is about 2 doors down the hallway,
Okay,
and we're slicing you up like a loaf of bread.
right.
This is
My femur.
the ball and
Yeah.
socket of your hip joint.
Okay.
Here's your bladder.
Oh,
And we're coming down, and
Yeah.
it's behind your femur bone in the gluteal muscles.
right,
Right here.
right.
While you and I can see this,
Mm-hmm.
it's not quite as discreet and as we typically would see in soft tissue mass.
Okay.
It's right there.
Okay.
We're gonna need to evaluate this.
Mm-hmm.
But I'm not 100%. It's a problem because it's there
Yeah.
and it's uncomfortable.
Mhm.
How much of a problem you and I are gonna need to discuss.
Okay.
This has some features, actually quite a bit of features, with this nondescript nature that kind of flows into the surrounding tissues. Some of this does look like what we would see in a condition known as myositis ossificans, which
Okay.
is inflammation of the muscle.
Right.
Myositis ossificans is not just inflammation of the muscle, but it is inflammation of the muscle where it turns into bone.
It's calcification.
But I'm not seeing a lot of calcification on this on
Okay.
the MRI. But that doesn't mean that it doesn't exist.
Okay. So another, I don't mean to interrupt you, but another piece is I have a lot of inflammation in my body because for a couple of years I was treated for psoriatic arthritis, and then they determined that it's just regular arthritis.
Are
So
you
I get
on
these
any
flare-ups.
of,
diclofenac is the only thing.
You're just on diclofenac.
Mm-hmm.
Interesting, because
Yeah.
actually diclofenac is part of, or indomethacin is actually part of the treatment for myositis ossificans, so the prevention of it.
Yeah.
I'm not seeing a ton of calcification, so
Right.
with that, I would say, can I say with certainty that that's what it is?
Mhm.
Definitely not.
Okay.
One thing is that if we were to get a CAT scan,
Yes.
the mineralization pattern of that can often be highly suggestive of myositis ossificans.
Okay.
In that, if that is what it is, and if it is mineralizing, it does so typically in a very reproducible pattern
Mhm.
that virtually nothing else does that.
Okay,
And
so it's very unique to its pattern. The pattern's
Yes.
unique and
So-
it's very
So
indicative.
if we have a CAT scan that
Yes.
shows calcifications and shows the ossification of bone formation in that specific pattern,
Right,
then we can say with a high degree of certainty that that's what it is.
okay,
And then you and I can outline what we're gonna do about it.
right,
If it doesn't show that, then we're gonna need to do a biopsy.
biopsy, I figured that.
If we're going to do a biopsy, there's a number of different ways that we can do that,
Mhm.
but this would be very amenable to what's called an image-guided needle biopsy, where
Oh,
our
good.
radiologists do this
Oh,
under
good,
CAT scan
okay.
guidance,
Yeah.
and they literally direct the needle right into it.
Sure.
And they can use that CAT scan to help direct it into the area of this that's gonna get us the highest yield,
Yield, right.
to get us meaningful.
Right, the best sample. Would they do multiple samples? Okay, yeah, all right. But it's not gonna be a core and it's not gonna be a
It's gonna be
decision.
it's gonna be a core.
It's gonna be a mini core, a smaller core, not like a cheese wheel core.
It is. It's a core, which is really just a slightly bigger needle.
Okay, I'm cool with
It's
that.
done. They give you a little bit of medication to take the edge off.
Yeah.
You're awake.
Yeah.
They give you a little bit of local anesthesia here.
Okay.
And they literally direct it under CAT scan guidance
Mm-hmm,
directly into this area
Cool.
to take core samples.
Right.
They probably do this for about 5 of my patients a week.
okay,
And they are really good.
I'm assuming.
And every week,
Yeah,
I work together with my pathologist and
Mhm.
my radiologist to make sure that my radiologist follows the track that I want them to,
mm-hmm,
that our pathologist and I and our radiologist are seeing the same things the same way, looking for the same things,
sure,
so that we're all on the same page and contextualizing what it is.
okay.
It still takes about 2 weeks to get a result back
Right.
after that.
Right,
So
that's fine.
That's,
I can wait.
it's a painful waiting period.
It won't be for me
but-
because I've already had like sarcoma in my head and now that's kind of leaving my head. So I'm feeling amazingly great right now.
So
I don't
unless
care.
the CAT scan if the CAT scan's indeterminate,
Yeah.
then we're doing the biopsy.
That's fine.
If the CAT scan is highly suggestive, if not
Indicative?
demonstrative
Yeah.
of myositis ossificans, then we're gonna pump the brakes.
Okay,
So there's kind of 2 main branches.
I get you.
If we're on the myositis ossificans branch,
Mm-hmm.
things get still a little complicated.
How so?
It's painful,
Yes,
so we're probably going to want to take it out.
I figured that.
But if you take it out too early while it's still inflamed, the recurrence rate goes way up.
Okay,
So in myositis ossificans, we typically want to not operate until it's really mature,
okay,
and it doesn't look like it's yet mature, but the
Okay.
CAT scan can help us.
okay, okay.
So, and that's where the annoyance comes in, because you're still sitting on this thing
Yeah,
and laying on this
Well,
thing
Yes.
she's
over and over.
relieved that it's not a,
yeah,
So it is not clearly a sarcoma,
Yes.
but it could be.
Okay.
And I want to keep those eyes open as
Sure,
you
but
do
the
still have
probability is less.
some, yes.
Okay,
I think that there's a very real chance, and that actually would suggest that if
Yeah.
I needed to guess,
yeah,
I would say I'm going to guess that it probably isn't a sarcoma,
right.
even though I spend my entire life
Playing with them.
managing
Yes.
sarcomas.
Yeah, so here's the
You
thing,
do
is I
also
will not
have some-
hold that
yeah,
to you,
yeah.
all right? I won't.
Well, I need to
Yeah.
make sure that you
Yeah.
fully understand that there is a possibility. There are some other things like desmoid tumors that could look
Mhm.
like this as well.
Yeah.
Certainly some sarcomas could look like this, though a little less likely. If this is a sarcoma, we have a whole team that we
Yes.
work together
Yes.
with in a
I'm
multidisciplinary
confident in your guts
fashion.
and your abilities, yeah.
You do also have a little bit of tearing at your hamstring origin.
Yeah.
So that may also be contributing to some of the discomfort.
Okay,
But this is close to where your sciatic nerve comes out.
yes. And
which
I did have
is-
sciatica pain for like, when was that? Haley was just a baby, so about 8 years ago I had a sciatic issue and they gave me a shot and it was all gone. It was done, it was fine.
So this mass is here, your sciatica nerve is right here.
Okay, yeah.
So when you're sitting or
Yeah.
laying and pushing it, it could
Yes.
be pressing on that. It is a little bit firm, so
Mhm.
that may be contributing to some of your symptoms.
Yeah.
If we were to excise this, we would need to
Be
protect
careful
your
of that
sciatic nerve.
For sure.
That's kind of what we do.
So I'm gonna repeat what I've heard you say so that I can aid in my own comprehension. So the odds are fairly good that we are looking at this, and I know what you're saying,
Yeah.
what it is, but I can't remember the words.
Myositis. I can write it down
Myositis.
for
No,
you.
it's written down here, actually. It's
Yeah.
in that morning, the happy morning report.
Yeah.
We call it, because we have like suffered for like 4
The
weeks.
other report was very gloomy.
Very
So-
gloomy, very gloomy. The happy
I
one
can
said,
under-
myositis, ossificans.
Yeah.
Okay, so
And-
that's what we're
and
thinking
I-
this is.
I think that it was, so, our radiologists, they do lots of
Tons of
soft
these.
tissue
Yes,
masses.
of course they do.
Because we're here and they all
Everybody comes to you.
So advanced radiology is excellent radiologists, very good quality, but they're used to seeing things that are like rotator cuff tears,
Yeah,
meniscus tears.
Right.
So when they see a soft tissue mass, I want them to be alarmed by this.
okay,
I want them to see it. I
Yeah.
want them to flag it, and to
Yes.
send it to us,
yes,
though sometimes they put the cart before the horse.
Yeah.
I think that this is appropriately heightened awareness of.
good,
I have my antenna up.
yeah,
We need to look at this.
yes.
We need to investigate it. And we need to do our due diligence.
Mhm.
I definitely have the ears perked.
Yeah,
I definitely have the antenna up.
yeah,
But I'm not yet convinced that this actually is something that we actually need to be worried about.
right.
But I need to prove to myself that we don't need to be worried about it.
I got it. So right now, we're looking at probabilities in some ways,
Yeah.
okay? And so we're saying that the probability of it being a sarcoma is limited, but still possible.
Yeah.
But the myositis ossificans, that seems to be the bigger probability. We're gonna do a CAT scan. If needed, we'll do a biopsy. And
Yeah.
either way, at some point, this is probably gonna have to be taken out,
Yeah.
okay? And when it is taken out, if we think it's more of the ossificans, we have to let it mature a little bit so that it's a solid piece, we can remove it in its entirety, reducing the likelihood of it returning. Okay, and so then that's gonna be that. And so that seems to be a little bit of time choice.
Correct.
There's a little bit more of a flexibility, it's not an emergency situation. If we get a situation on the CT where it's coming out, it really does look like a sarcoma.
Then we're gonna do a biopsy.
Still do a
If
biopsy,
so
right?
if it looks like a sarcoma,
Yeah.
or if it looks like anything other
Other.
than myositis ossificans.
Right, because there are other
We are
options,
going to,
right?
even if it looks like it might be desmoid,
Yeah,
we're still gonna recommend a biopsy.
okay, that's fine with me.
If we do the biopsy,
Mm-hmm,
and the biopsy does show sarcoma.
Yeah.
So now we're on
Oh,
that
the other
part of
half.
the decision tree.
I'm at the right place with the right people,
Well,
that's my
then
part.
we gather our team, depending on what type of sarcoma, there's more than 70 different subtypes that are recognized by the World Health Organization with various levels of
So
rarity.
you say that
But
on
they're,
YouTube.
they're all uncommon.
Yeah,
And then you divide uncommon by 70 and it's really uncommon.
yeah,
But depending on which type, what grade or how aggressive it is under the microscope, that will help us determine the overall treatment
of
course.
course,
If it is a sarcoma,
Mhm.
surgery is going to be part of the plan.
of course.
The next question is, what staging do we need to do? What other studies do we need to do? Do I need to do a CAT scan of your chests?
Right.
Otherwise?
Yeah.
And would we recommend adding radiation?
Yeah.
Should we do the radiation before
Before
surgery?
surgery or after?
surgery? There's benefits to each,
Mhm.
there's downsides to each.
Right.
And you're young, you're active, you're healthy, depending upon the biologic aggressiveness and the biologic subtype. We may even consider giving you some medications for it too.
Mhm.
That's why we meet every week as
Sure.
a multidisciplinary team to
Yeah.
discuss.
Yeah.
We actually do have some multidisciplinary clinics,
Mhm.
basically every week, once a week.
Yeah.
We have a clinic so that if there's any concern as to what this is, even if it proves to be a desmoid, which is benign,
Yeah,
we may still have you come to see us in follow-up for a multidisciplinary clinic,
sure,
because our medical oncologists actually also take care of those.
Yeah.
With us, and there are sometimes some non-operative management options that we would do.
okay,
That's kind of the only things that I can realistically imagine that it might be that wouldn't need surgery or would result in surgery eventually. The desmoid tumor, the classic appearance of a desmoid, but it could.
mhm,
Is desmoid
Or-
bad or good?
Those are benign,
benign,
Benign, okay.
but annoying.
yeah,
But we often treat them without surgery.
yeah,
And there are some vascular malformations and anomalies. Again,
Mhm.
not the classic appearance of it,
mhm,
but a slightly different way that we would do the scan
mhm,
that sometimes wouldn't be, this doesn't quite highlight whether it could be just an abnormal collection of blood vessels.
right,
But my suspicion looking at it, that's a little less likely.
okay.
So time will tell.
So I'm feeling like this is the more likely thing, which is the myositis.
If
I'm
I-
gonna learn how to say that by the end of the day.
If I needed to put odds on it,
Yes,
I would say it is probably 60% benign, and the most likely of those benign entities would be myositis ossificans,
Mhm.
and about 40% risk that it could be malignant.
okay.
So there's still a significant chance that this
Sure.
could be a
But it's
problem.
better than the way we walked
But
into
better
here.
than
Yeah.
95% malignant.
Yeah. Yeah.
5 to 10% benign.
Yeah, that's what we walked in
I
here
would say if I
thinking.
needed to guess,
Yeah.
I would put my chips on this being benign.
Good.
But I think that we need to hedge our bets and make
Sure.
sure that we.
I'm gonna be cautious and do the right thing.
Exactly.
Great. Great, so the CAT scan, CT scan, she said she was looking to see if there's one
Let's see if they can do it
possibility.
today.
Which would be-
I'm gonna have Nina make some phone calls if she hasn't already.
Thank you.
If you don't mind my asking, sometimes it impacts it. What insurance do you have?
I have Care First, Blue Cross Blue Shield.
That is almost impossible to get that done here today,
No,
because Care First is, they typically require prior authorization to have it done at this site.
okay.
But we can still make some phone calls.
Yeah, that would be wonderful.
We could call Dr. Regular and tag him too.
No, it's
No, it's the
an
insurance,
it's on the
it's not
insurance
Dr.
side.
Regular,
And
yeah.
we can order it, they can
Yeah.
order it, it doesn't really matter. It's a Care First is
Yeah.
I was
See, I've
really
been told
hoping
they're
that
so
you were.
good. Yeah.
They are good, but, they have one fatal flaw,
Yeah,
and that's it.
and that's it. They want pre-authorization. Yeah.
They really give us a hard time for any imaging done in this building.
Okay,
Technically, this building is part of the hospital,
yeah,
which has a separate fee associated with it.
I
It's
gotcha.
cheaper to perform everything else, but then there's an added fee.
Does it help if you tell them that I'm hysterical?
So,
You're a hysterical patient, no.
unfortunately, doesn't really help. Where do you live?
We live in Bel Air.
Okay.
Yeah.
You're gonna have an easier chance
Yeah.
going to White Marsh.
Yes,
So if you, which is on the way home,
yeah,
we can make the phone call today, but more likely, you could probably get into White Marsh
yeah.
today,
Yes.
get it done,
If we can get it today, that would be
and
great.
that doesn't require prior authorization the same way.
Okay,
Typically for Blue Cross.
so if
The,
you're,
the challenge with Blue Cross is this location,
Yes.
not so much the scale.
okay. So here's my question. If you're going to call Blue Cross and try and get it done here.
We're gonna try to call downstairs and see if
Downstairs.
they can do it nonetheless.
Okay,
And if not, then what we'll do is we'll put the script in for you,
okay,
and then you can call White Marsh to
Yes.
see if they can put you into it.
perfect, perfect. You're the man.
Yep.
Thank you so
Pleasure to
much.
meet you.
Thank you.
Yeah.
You are amazing.
Yeah.
You just made me feel so much better. I can't tell you how your calm demeanor really helped everything.
I think if you have any issues,
Yeah.
just give Kennedy a call in my office,
Okay.
and we do this all day, every day.
Great.
This is what we do,
Okay.
and she can help navigate any issue.
Great. So we're gonna wait to hear
Yeah,
from
why don't you
you.
sit tight for just a moment?
Thank you so much. And